now I will introduce our next speaker. The next speaker is Emma Stanley, who is a PhD candidate in biomedical engineering at University of Calgary in Canada. She's currently pursuing her PhD with a medical imaging specialization, and her research focuses on improving understanding of bias and fairness in AI and medical imaging analysis, but she's passionate about responsible and ethical AI in all fields. And Emma, you have the floor. Thank you.
Thank you. So thanks so much. I'm really honored to be here amongst so many researchers that I admire and that kind of inspired me to pursue this area of research 2.5 years ago when I started my PhD. And at the time, I remember kind of being new to this whole world of AI and medical imaging, and then coming across the Czech exclusion paper by Dr. Kasemi's group, obviously the precursor to their Nature Medicine paper, and just being struck by how important and urgent these problems of bias and fairness are. And then, of course, many other studies started coming out about models trained on other imaging modalities that also resulted in disparate outcomes between demographic groups. And I was interested in trying to understand how those biases actually manifest in deep learning models. So I did what I could with the data that I had access to, but over and over again, I was frustrated by the same issues. One of those being that most of the medical imaging data that we had access to didn't even have information about more than one or two sociodemographic attributes. And even when it did, so many of those minority subgroups were just too small to confidently come up with meaningful conclusions. And even more challenging, I just kept thinking, with factors like annotation bias and scanner effects and all these other unknown confounders, how are we really supposed to quantify and understand algorithmic bias if we don't really know all the sources of bias that are actually in the data? And I remember expressing these frustrations in one of our lab group meetings, and it was suggested just to make my own data set with bias that I could model. And at first I thought, okay, that seems really complicated. But over time, I realized that to actually be able to systematically, objectively, and comprehensively study bias in medical imaging AI, maybe that is what is kind of missing in this research space. Essentially a way to generate data that allows you to study bias in medical imaging AI models that isn't limited by the size or composition or the unavoidable and unknown biases and confounders that are in real medical imaging data. So that's what led us to develop our simulated bias in artificial medical images framework. So just briefly describe, the core of this framework is the ability to add bias effects to synthetic medical images in a controlled manner, so that you can then objectively study the impact that those biases have on deep learning pipelines. And there are a few key characteristics that we wanted this framework and these datasets to have. One, to be realistic, so to represent real medical imaging data the best that we can. Two, to be controlled, to ensure that we can fully understand and control for all the bias in the dataset. And three, to be flexible and modular enough to enable modeling various bias scenarios and various types of bias. So I'll talk about how we implemented these ideas into the framework, which we've initially built around structural neuroimaging data, but as you'll see later, we don't at all think it's limited to this. So the goal is to introduce realistic deformations to act as disease or target effects that the model will use for the prediction task, and then bias effects, which are not intended to be used for the prediction task, but could lead to performance disparities between the groups with and without these effects, and then also effects that represent distinct subjects in the data set. So to do this, we generate velocity fields through nonlinear registration of healthy subjects. We use the ICSI database to a template brain, and then we fit PCA models to those velocity fields. So for the disease and bias effects, we mask those deformation fields such that they're restricted to specific regions of the brain. And then for subject effects, we fit the models to the global deformation fields. So then we use these as generative models for sampling effects of various magnitude and introduce them to the template image through scattered grid B-spline interpolation. This just enables a smoothing around these effects such that transformations are diffeomorphic. So this whole framework is just based around the idea of systematically augmenting a template image with these classes of effects in a controlled manner. So for a binary classification task, we sampled these disease effects from a bimodal distribution of effect magnitude along the first principal component of variation. And these effects are what we want the model to distinguish between. And then to a predefined portion of each disease class, we also add bias effects. And then we integrate the subject effects just to model this inter-subject variability. So the sampling procedure is repeated to generate a data set of this user-defined composition and size. And then to make it controlled, we need to make sure that all the sources of bias in the data are actually fully understood and quantifiable. So we already know which images actually have the bias effect from our previous sampling procedure, but actually the models can also pick up on a source of bias other than our intended effect. And that's the distribution of subject and disease effects that we're adding to the data sets. So for example, since we're generating a relatively small finite amount of data, even though we sample subject effects from a single distribution, the actual underlying distribution between disease classes and bias groups could be different. So therefore, we might actually see subgroup performance disparities, even without the addition of that actual bias effect that we want to model. So to control for this, we stratify the effect magnitudes for each bias group and disease class such that they come from similar distributions. So in practice, it looks something like this, where each disease class has the same underlying distribution of subject effects. And then within each class, the bias groups have similar underlying distributions of subject and disease effects. So with this stratification in the CNNs that we tested, we end up mitigating any additional bias introduced by these distributions just down to about a 1% difference in true and false positive rate disparities. But actually defining these distinct distributions of simulated subjects also allows us to perform an even more rigorous analysis of bias and actually account for that small amount of bias introduced by the distributions, because we can generate multiple data sets with these same subjects, either without the bias effect we want to study, or with the bias effect in different spatial locations, for example. And because the data set for each of these bias scenarios has the same simulated subjects, these are essentially counterfactuals of each other. So when we put these counterfactual data sets with the same training and test splits and identical weight initialization and deterministic training through a model, we are performing what can essentially be seen as like in silico trials of the direct impact that that bias effect that we added has on the performance or other outcome measures of the model. So just to give an example of this, we defined a data set composition where we have a greater proportion of the disease class containing images with the bias effect compared to the non-disease class. So we would then expect this model to maybe use the bias effect as a shortcut for predicting the disease class and then result in performance disparities between the bias and non-bias groups. So we generated 3 counterfactual data sets where we want to study if the proximity between the disease and bias region affects performance of the CNN, which initially has spatially localized receptive fields. So in addition to subgroup performance disparities, we also looked at the ability of just smooth grad explainability and identifying these known bias regions in our data. And then we also apply 3 bias mitigation strategies to see how well they perform at reducing those disparities caused by the specific bias effects we introduced. So there's more details in the preprint that should be on archive in the next day or two, but just showing a couple of results here. We can see that the bias regions are highlighted here in the saliency maps. And since we know exactly what the model should be looking at in this setup, the setup facilitates a really highly objective way of studying explainability methods. For example, this could help us investigate like which explainability methods are good at identifying sources of bias and under which conditions. We can also use these data sets to rigorously benchmark bias mitigation strategies, because we see in our experiments here that just simple reweighing actually perfectly mitigates performance disparities here. But we could simulate various other bias scenarios that might be hard to study with existing real medical imaging data sets, but that could be encountered in clinical practice, for example. And we can use this well-defined structured setup to better understand the situations that certain mitigation strategies might work best in and situations that they might fail in. So finally, we wanted this framework to be really flexible in its utility for studying various types of biases and the impact that they have on medical imaging AI pipelines. So just using this general setup for generating data, pretty much everything can be user-defined, including the representation of bias groups, the number of bias groups and disease classes, the types of bias effects. So obviously, we've just started modeling morphological effects, but This could easily be modified to integrate like intensity-based effects, sort of emulating like scanner artifacts, label or annotation bias, as well as distribution shifts. It's not limited to the ways of introducing effects. So as I mentioned, we are using PCA models in these experiments, but when we were first developing this framework, we were just using simple displacement vectors to model effects, or you could even replace those PCA models for something like GANs or diffusion models. And even though we've only approached this for structural neuroimaging data so far, I think that the high-level procedure of just starting with a template image and then systematically augmenting it with whatever target or bias effects are relevant, this can easily be expanded to other modalities and organ templates. And this is really kind of the crux of this whole framework. Yeah, so just to wrap up, we hope to have made some progress towards a more controlled, systematic, and objective evaluation of bias in medical imaging AI, but there is still a lot of work to be done, including adapting to other modalities, using these types of data sets for studying how bias manifests in different model architectures, as well as benchmarking and developing new bias mitigation strategies, and even integrating domain knowledge to more faithfully model real pathology, for example. And finally, I do want to say that we are a small team who put this together. So my hope is that many of you in the FAME community will be able to add your own perspectives and expertise to expand and improve on this foundation, so that with more studies revealing like what kind of models can be biased and how those biases are encoded, both on real world data and on synthetic data like this, that we can all continue working together to build out more responsible, robust, and fair medical imaging AI. Yeah, and thanks again to the organizers for having me. I remember last year at this event, I was so excited just to see my papers like highlighted in the introduction slides. So actually having the opportunity to speak this year is really special. And I think we have a couple minutes for questions maybe, but I'm also happy to discuss details or other further questions over email.
Thank you very much, Emma. That's a really interesting talk, and it's great to have you here. I wanted to ask one quick question. We've got one question in the chat, I think, as well, but I'll ask one quick one about the way in which you define your groups. I think you've just got a single level of groups at the moment in your sort of model. How would you deal with things like intersectionality, about interactions between groups, or even groups that are unknown, for example?
Yeah, that's a great question. That's kind of what the direction I'm wanting to go towards next with this is, yeah, really studying like intersectionality, because I think that is one of the biggest limitations of using real data sets, right? Is that when you get into those like intersectional levels of demographics, the sample size just gets so small and it's so hard to study in real data sets. So that is something that I really want to work on with this framework. And I think just kind of as a first step, for example, we could have groups represented by like kind of like here where we have the presence or the absence of bias effects. We could have different magnitudes of bias effect or different locations, or even kind of approaching intersectionality from the angle of, combinations of biases. So morphological biases and how does that interact with, for example, like intensity biases and distribution shifts. So yeah, that's something that I'm really looking forward to kind of working on with this. And I think, yeah, there's definitely a lot of ways to approach that with this framework.
Okay, thank you. And we've got one question in the chat as well from Steph. How would you simulate patients in different stages of treatment?
Yeah, that's a good idea. I mean, I think it kind of depends on what you are defining as treatment when you're using this kind of framework to model, because I mean, in what we've worked on so far, it's kind of very arbitrary, right? Like we're just choosing an arbitrary region and simulating, adding effects from a normal distribution of magnitude. But I think if you wanted to potentially model like, treatment duration, you would have to then specifically, for example, define like the effect magnitude, for example, that you are choosing to be like maybe untreated versus different stages of treatment, and just being able to, label and define those in your own framework. When you're applying this, I think, it's pretty flexible in terms of how you want to choose to model that.
Okay, that's great. There's at least one more question in the chat, but maybe I can ask you to have a look at that in the Q&A afterwards, and you can
Yeah,